This presentation is over congenital heart disease with cyanotic defects. In other words, they have a right to left shunt or some type of decrease in pulmonary blood flow such that you have the blue baby. So congenital heart defects, as mentioned before, typically fall into two categories. Depending on your physiologic classification, some people use the parallel and in series and single ventricle. But in general, it's easier to remember it as pink and blue. So acyanotic defects we've talked about in a previous presentation over ventricular septal defect, ASD, PDA, and coarc, where you have a left to right shunt, or you have an increase in pulmonary blood flow, which remodels the right side in the pulmonary circulation, versus the cyanotic congenital heart disease patient, which has a right to left flow, where you have deoxygenated blood going from the right side to the left, compared to left to right. Other issues you can have, again, include pulmonary blood flow issues, etc. And I think the 5 T's is how some people remember this, but is tetralogy of flow, which involves a combination of VSD and decreased pulmonary blood flow, transposition of the great vessels, where you have parallel circulations that only communicate through a VSD or ASD, truncus arteriosus, which ends up being deoxygenated blood going to both the pulmonary side but also the systemic. Total anomalous pulmonary venous return we won't talk about today because it gets into partial and it's pretty complicated. And then finally, hypoplastic left heart syndrome, which is pretty common as well. And we'll also talk about Epstein's and in the context of cyanotic defects. So once again, cyanotic congenital heart disease is broken down into decreased pulmonary blood flow and mixed blood flow, as may occur through a septal defect, decreased pulmonary blood flow as may occur through tricuspid or pulmonic valve atresia, etc. And then decreased pulmonary blood flow includes tricuspid atresia, tetralogy of flow, and mixed blood flow includes transposition of the great vessels, VSD, TAPV, which we'll talk about, truncus, and hypoplasts. So cyanotic heart disease is basically an obstruction of pulmonary blood flow and an anatomical defect between the right and left side of the heart. Either one of those could be the cause. Blood can have difficulty exiting the right side of the heart via the pulmonary artery or pulmonic valve, or have limited pulmonary flow in general. Pressure on the right side of the heart can be greater than the pressure on the left. So if you've got a communication like an ASD or a VSD, the blood's going to go to the based on the pressure gradient from right to left. So you end up putting deoxygenated blood into the left heart. And hypoxemia and cyanosis are hallmark symptoms. So if you are doing non-cardiac surgery and you're in a big center, you're not going to be doing a cyanotic, period, whether it's a previous repair or whether it's a congenital heart defect, unless you're one of the pros from Dover. So we talked about increased pulmonary blood flow, some of the consequences and some of the ways of dealing with it. In cyanotics, you typically have decreased pulmonary blood flow, and cyanosis is the major feature. And you have a right to left shunt, often through a VSD, as you can see here. You can also have decreased PO2 and chronic hypoxemia. Here's the shunt across here. 68% is the SAT over here because of mixing instead of 60% like it is in the right atrium. It's 68 because you have mixing. A little bit of left to right there always exists despite a right to left shunt. So you end up having blood with a SAT of 68%, mixing with the SAT of 95%, delivering a SAT of 75%. So you end up having a right to left shunt and chronic hypoxemia. You end up having polycythemia as a result. Sometimes the hematocrit PCV is 60 to 70%. Along with the cyanosis. And you have a little change in PO2 even with increasing the FiO2 because of the shunt. You can go up to 100% all you want, but often you're not really going to do a whole lot to this SAT that the rest of the body is seeing. Here's is tetralogy of flow. Actually, you've got the pulmonary the RV outflow tract stenosis, you've got the overriding aorta, you've got the VSD, and you've got all the hallmark features that's going to decrease pulmonary blood flow, along with right to left shunt. So we talked a little bit about in a previous presentation about general considerations for left to right shunts. Right to left shunts, a little different. You do have to paradoxical air embolism, even though it's a right, especially because it's a right to left shunt, as we talked about before with your tubing and your syringes. But also you have to avoid dehydration, because a lot of these patients are polycythemic, and you're wanting to get the hematocrit down to 55 or 60, believe it or not, from 60 or 70. You also want to maintain an adequate systemic blood pressure, so you end up having less right to left shunt than you want. Bradycardia is very poorly tolerated in these patients. Of course, in any child is poorly tolerated, but pulmonary, you're going to have cyanosis, a blunted response to hypoxemia. You're not going to have the typical increase in minute ventilation from hypoxia. You have VQ abnormalities, and you have positive pressure ventilation, which can increase dead space ventilation as well. So a lot of things are affecting pulmonary. Your induction changes a lot. You have prolonged inhalation anesthetic induction with right to left shunts, and it's accelerated with intravenous agents. So a few things about right to left shunts and anesthesia management just in general. You're going to want to limit the increase in pulmonary vascular resistance. Opioids may be advantageous. You also want to avoid hypoxia, hypercarbia, and high airway pressure. So if you have hypoxemia, hypercarbia, high peak inspiratory pressures, using a lot of PEEP, you're going to increase your pulmonary vascular resistance. You're going to shunt more deoxygenated blood from right to left, and you have a lower oxygen saturation. And then, of course, you got to balance that with the SVR thing. If you drop the SVR too much with your volatile, that's why opioids are advantageous. You end up also shunting more, and also bad things happen. And then if you have too much SVR, you end up shunting left to right and causing overload of the pulmonary circuit. It's just a very tricky deal, and we'll talk about the different things that can affect that in a moment, which is just about everything we do. Again, inhalation induction is delayed. If you look at the FA, in normal versus right to left shunt, it takes a long time for inhalation anesthesia to occur, and a lot of people like to slip a little nitrous oxide in there for the second gas effect, but you need to get rid of that poison as quickly as you can. Ketamine is very nice. Again, you have a accelerated intravenous induction. Ketamine works very well for TETs and just about any cyanotic. So this is a very important slide on flow distribution and some of the things that go on in the operating room that affect your flow. Of course, if you flow more left to right, you're going to end up having systemic hypotension and less shunt. But if you flow more right to left, you're going to have better systemic blood pressure and perfusion, but at the cost of lower oxygen saturations. So some of the factors increasing pulmonary blood flow. If you have hypocapnia and you're using a pulmonary vasodilator, you're going to have more shunt left to right. If you're going to have increased SVR, you're going to shunt more left to right as well from sympathetic stimulation, surgery, intubation, etc. Hypothermia also increases your SVR, which is not exactly advantageous. Then things that are going to increase your systemic output and increase pulmonary vascular resistance are going to be hypoxemia, hypercapnia, high hematocrits like all the TET babies have, PEEP, high peak inspiratory pressures are going to shunt more right to left as well, along with decreased SVR from vasodilators like volatile agents. That's why a lot of these cyanotics, you're using higher doses of opioids and limiting the amount of vasodilators that you use, like isoflurane and sevoflurane. So a few key points. PDA may represent left to right or right to left flow in the newborn, which may be advantageous if you have pulmonary or systemic blood flow that's reduced. If you've got a patient that ends up having low systemic blood flow, we talked about with coarcs, sometimes the PDA is useful. If you have reduced pulmonary flow, pulmonary blood flow, such as if you have pulmonic valve stenosis, if you have a TET baby, sometimes the PDA has some utility as well. So PG1, use of prostaglandins to keep that PDA open, may be something that you're on. In the setting of congenital defects that limit pulmonary flow, they may both offer the ability to improve pulmonary and systemic flow. So sometimes, again, you're using a persistent fetal circulation to your advantage. Causes of decreased pulmonary blood flow include right to left shunt across a defect and limited pulmonary blood flow due to stenosis. So those are the two bottom line causes of cyanotic heart disease. Inhalation induction is delayed, and IV induction is faster or enhanced in patients with right to left shunts. So taking advantage of this, ketamine may be a better choice. Opioids may be a better choice as well. And then left to right shunts, as we talked about before, have no real effects on speed of induction. So tetralogy flow is a complex congenital condition involving several heart defects due to abnormal development during the first 8 weeks of pregnancy. These features are a ventricular septal defect. Then there's a narrowing of the valve leading to the pulmonary arteries, the pulmonic valve. There's also going to be right ventricular or thickening of the right ventricular hypertrophy. And finally, there's going to be an overriding aorta that overrides the VSD that sits above both the left and right ventricles, such that deoxygenated blood mixes with the oxygenated blood from the LV. Some of the consequences of tetralogy flow: if the pulmonic stenosis is severe enough or pulmonary artery pressures are high, the RV ejects more into the aorta and causes more cyanosis. The more blood that goes through the VSD from the RV as a shunt or a right to left shunt, the more deoxygenated blood is ejected into the aorta from the LV, so you end up having lower sats. And depending on how much blood is shunted in this manner, the lower the oxygen saturation. So looking at again, the heart as a house, you've got a left atrium, you've got a right atrium, you don't have an ASD, but you have a nice big VSD, so you've got blood flow across from the right ventricle to the left ventricle, or vice versa, left to right. You also have deoxygenated blood going out to the periphery, and you have a decrease in pulmonary blood coming out because of that narrowed pulmonic valve. So we've all heard about TET spells, or hypoxic spells, characterized by a period of rapid and deep inspiration, irritability, prolonged crying, which is going to increase your pulmonary vascular resistance and increase your cyanosis. The spells peak at about 2 to 4 months and can actually lead to death. Treatment involves picking the child up and holding them in a knee-chest position. And what that does, and you see a lot of older TET babies squatting, it's going to compress your femoral artery and increase your SVR and have more blood going left to right than right to left, which is the easiest way of thinking of that. Decreasing respiratory rates is essential as well. Oxygen has little effect due to shunt, so really oxygen is not going to help you out. But a balloon valvuloplasty with a pulmonic valve and outflow tract would seem to be useful, but it's not very useful here because basically of the infundibular muscle spasm that they have. So some of the things that you do, you have some beta agonists that work. Indoral was very popular. Sepsis or infection and vasodilating drugs are going to reduce your SVR and cause more problems as well. So all these things all interact to cause cyanosis with TET babies. So what can we do in our world? We obviously can't pick the child up and or make them squat, but pharmacologic management of hypercyanotic spell or TET spell, basically the cause is a decreased pulmonary blood flow and you have more shunting right to left, or a decreased SVR, in our case volatile agents, increased pulmonary vascular resistance from crying, or in our case, high peak inspiratory pressures, hypoxia, hypercarbia, acidosis, hypothermia, PEEP. These kind of things are going to make you have more right to left shunt. So treatment of the TET spell actually is to increase the volume and minimize the pulmonary vascular resistance. You're going to increase the FiO2, hyperventilate, increase the SVR, although you can't do it in the OR, needed chest would be nice. So instead, you increase the SVR by increasing resistance with phenylephrine or pure alpha drug. I haven't used any vasopressin in kids, but you would think, well, that would be perfect because it doesn't have any effect on the pulmonary receptors, but I'm not sure. That's just something that we do culturally where I work. Consider a beta blocker as well to reduce infundibular spasm. This is all because of sympathetic activation, and you end up having the squeezing of the RVOT. So one of the ways of dealing with this decreased pulmonary blood flow in the TET baby, not just the right to left shunt, but also you're getting less blood to the pulmonary vasculature, is to improve the flow into the pulmonary artery artificially. Here we have a modified Blalock Taussig shunt. Blalock and Henry worked at Vanderbilt and developed this shunt. You have a Gore-Tex interposition shunt placed between the subclavian artery and the pulmonary artery on the same side. It's a nice little piece of Dacron. Usually it's about 5 millimeters or so. And it basically shunts blood from this right subclavian over to the right PA. So if you've got some type of stenosis here, you end up getting some blood flow to that PA from the right subclavian. So what you have to consider here is that also means that some of that blood that would be going out to the brachial artery is being shunted down here. So this isn't going to be an accurate indication of what your blood pressure really is. But it improves blood flow to the pulmonary artery to provide more oxygenated blood over to the LV and improve things. It's a very popular procedure for all ages, especially under 3 months old. because basically this is something that can be taken down when you have a more definitive procedure. Some of the other shunts, the Waterston and the POTS, are just no longer done because this is just a very resilient procedure. It just does affect a lot of your subsequent anesthesia monitoring. So a BT shunt is very nice at a very young age because you don't really want to be operating on a kid that young and putting a patch on, this and that, in the first 3 months of life. But in the first year of life, you can actually do a total correction of the tetralogy of flow. The total repair is carried out, of course, under cardiopulmonary bypass because you're doing a little valvulotomy here, and then you're putting a little repair patch here. You're also putting a patch here where the VSD is, and you're going to do the patch closure of the VSD, widen the RV outflow tract by resection of tissue, and do the pulmonary valvotomy. You end up getting a little pulmonic insufficiency here. The operative mortality is about 5%. Of course, in adult cardiac surgery, it's typically, I think, 1 to 2%, but there's a lot of modifying factors. So again, looking at the heart as a house, here's our tetralogy flow with our big VSD and our small door here, or narrowed pulmonic valve, and blue blood coming out. And then if you go in and you do the VSD repair, and then you do a little bit of work, a little valvuloplasty, and you end up widening this door, you get a little bit better flow out the pulmonary artery, so you end up improving that. You have to, of course, take down your BT shunt at this time, and then you get a little bit better oxygenated blood going out from the LV to the systemic circulation. Anesthesia for palliative procedures on TET babies, such as this BT shunt, is relatively straightforward as far as cardiac procedures go. It's a simple procedure with complex anesthetic management in a lot of ways, but lines after induction, inhalation induction is fine, but it's going to be delayed. And paralysis for intubation, watch for air once again. Arterial line, if they're critically ill, but typically you don't have to do that. But just remember, you're going to be putting the shunt on the right subclavian, so you need to probably do measure blood pressures on the left. Phenylephrine is typically used to maintain SVR and ensure adequate pulmonary flow. And then we're going to extubate these folks post-op unless they're unstable or you've got some de-recruitment and even lower oxygen saturations, things like that. Anesthesia for tetralogy of flow repair is different, in this case a Fontan. The goals of total repair are to close the VSD, relieve the RV outflow tract obstruction, and repair associated anomalies. Anesthesia is maintained with typically 10 to 20 mics of fentanyl supplemented with isoflurane. Some people go above 20. It just depends on the day. And higher doses of fentanyl minimizes the myocardial depression associated with the volatile agent for complicated repair. So it depends on the patient. Radial arc line placed in the arm with the best pulse, and typically it's opposite the previous BT shunt. Often they have a BT shunt. The Fontan, right here, as you can see, you're going to take the right pulmonary artery and you're going to hook it up to the SVC, and you're typically going to repair things. And then right IJ venous catheter is short to avoid interfering with the bypass cannula, and acute oxygen desaturation is treated with fluids and phenylephrine. So, key points over this section. Tetralogy of flow is a complex congenital condition involving several heart defects, not just one, including a VSD, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta, overriding the VSD. If the pulmonic stenosis is severe or pulmonary artery pressures are high, the RV ejects more blood into the aorta and causes more cyanosis. And the more blood that goes to the VSD from the RV, the more deoxygenated blood is ejected into the aorta from the LV with subsequent hypoxemia. These kids typically run around with a SAT of 70. Modified BT shunts anastomose between the subclavian artery and the ipsilateral pulmonary artery and improves flow in the pulmonary circulation. Is a very nice palliative procedure, very popular procedure. Complete and total repair of tetralogy flow includes patch closure of the VSD, widening of the RV outflow tract by resection of the tissue, and pulmonary valvotomy. Again, typically you get a little bit of regurg after the procedure. Use of volatile anesthetics such as isoflurane benefits patients with dynamic infundibular pulmonary outflow tract obstruction. But if you've got some RV dysfunction or if you're in heart failure, it's probably not a good idea to lean on your volatile. You may just be giving a little bit more fentanyl to deal with hypertension or tachycardia. Disadvantages of high-dose narcotic technique as used for patients with complex repair includes delayed extubation. And then finally, blue TETs benefit from fluid restriction. Pink TETs benefit from liberal fluids and fluid resuscitation. The hypoxic TET is going to get reduction of volatile because that means that you're dropping your SVR and you're pushing the blood over from the pulmonary that has a higher resistance than the systemic side of the SVR. Lower peak inspiratory pressures and lower PEEP to decrease your PVR, higher FO2, and hyperventilate to improve pulmonary blood flow, depending on whether or not you've got too much right to left or too much left to right. Volume and increased SVR can improve left to right flow and hypoxia. Neosynephrine is a very popular drug for this. Consider beta blocker to reduce infundibular spasm. Esmolol is a very high utility drug in this situation. That way it is fire and forget. You don't have to worry about it sticking around. You're not married to it like you would be with labetalol or metoprolol or any of the other beta blockers. So for procedures in TET patients, place the radial artery in the arm with the best pulse, which is typically opposite the BT shunt, and use a shorter internal jugular central line to avoid interfering with the bypass cannula. Going a little further down the rabbit hole, we're going to talk a little bit about tricuspid atresia, which is basically a tricuspid valve that is atretic. It's characterized by an underdeveloped right ventricle, an absent or atretic or underdeveloped tricuspid valve with at least some stenosis, if not no flow through it, and reduced pulmonary circulation. Obviously, if your tricuspid valve is shot, you're going to have decreased flow through the RV and decreased flow to the pulmonary artery. You also have a larger LV, small ventricular septal defect, and patent ductus arteriosus, which is and PFO as well, which improves your blood flow from your right atrium over into your LV and LA as well. You have a small VSD, you're going to push some blood from the LV to the RV, which is, even though it's small, at least it's getting some blood out to the pulmonary vasculature, which is going to pick up some oxygen and improve your SAT. In this manner, oxygenated and deoxygenated blood mixes constantly and shunt develops with hypoxia and cyanosis. So in trying to manage these patients with severe cyanosis and reduce pulmonary blood flow, basically if you've got a patent ductus, you're pushing some blood over from the systemic to the pulmonary side and vice versa. So PGE1 should be started in neonates with severe cyanosis to maintain patency of the ductus. The Rashkin procedure, which is a balloon atrial septostomy, using the foramen ovale or using a separate ASD that you create with the Rashkin, can be performed as part of the initial catheterization. So basically all you're doing is, if you've got an atretic or non-existent tricuspid valve, so there's no way for the blood to go from the right atrium to the right ventricle, you're putting a hole in the septum so the blood's going from the right atrium to the left atrium, so at least some blood is getting over from the venous return side. And often this is something that is working on its own anyway. Otherwise you wouldn't have the child wouldn't make it very long out of the womb. Improves the right atrial to left atrial shunt if the intra-atrial communication is considered inadequate, basically. So if the foramen ovale, which is typically open when they're born, is not large enough, you can expand that or even create a separate new ASD. So there are several different ways of managing this along with the Rashkin or the atrial septostomy. And one is the modified Blaylock toxic shunt, which basically is getting blood over to the pulmonary circuit from the left side. And even though you've got this foramen ovale, sometimes this isn't enough, and this ends up getting blood directly from the right subclavian over to the right pulmonary artery, which improves the pulmonary blood flow, and you can pick up some blood and carry it back to the pulmonary vein to the left atrium, and out we go, and improve the SAT. But staging depends on the blood flow through a VSD that you might have. Too little receives a BT shunt, and if you got too much blood coming over from the VSD, which is not a good thing, sometimes you get a pulmonary band. But it results in increasing blood flow to the pulmonary circulation with a BT shunt. LV volume load increases as the LV supplies blood to both the systemic and pulmonary circulations. And in the modified BT shunts performed, as you can kind of see here, using a small graft, typically the shunts performed to increase pulmonary blood flow followed in several months by bidirectional Glenn shunt, which is a little more, getting a little bit more blood flow and kind of solves the whole issue with the tricuspid atresia. So in patients with tricuspid atresia coming to the OR for their BT shunt, they all arrive in the OR on PGE1 to keep the PDA open. And complications of PGE1 include apnea, seizures, fever, and vasodilation. So you can drop your SVR as well. And a lot of that comes from the PGE1, but also because of the shunting of blood from the aorta over to the pulmonary circuit, so you have less systemic output. All infants are going to be hypoxic and worsen during the anastomosis of VT shunt or if crying. So when you start putting clamps on the pulmonary vessel to tie the VT shunt in, you're going to get even less pulmonary blood flow. You end up having a little bit more cyanosis. Arterial line is essential, obviously on the left side. No CVP or TE, no bypass circuit. Consider extubating in the OR, actually, because again, it's a simple operation in a complicated patient. But if the patient's very hypoxic and can't handle the clamping of the pulmonary artery, they're going to get cardiopulmonary bypass. Inhalation induction or IV induction, often they have an IV. You can also use some IM ketamine if you need to. Hypotension worsens a shunt, hypoxemia, so you end up using phenylephrine fluids. Heparin without cardiopulmonary bypass is about 50 to 100 units per kilo. And if you've done some electrophysiology lab work, this is kind of the same thing. You're just pushing the ACT up to around 250 or 300. And then excess pulmonary blood flow with the BT shunt can be managed with a lower FiO2. If you think about it, if you're trying to lower pulmonary blood flow because you've got the BT shunt in, you can always lower the oxygen from 100% to 21%, and that's going to increase your pulmonary vascular resistance. Well, hopefully we haven't lost anybody with as we descend through the rabbit hole. Pulmonary artery banding is another stage 1 procedure for tricuspid atresia. It's performed when the pulmonary blood flow actually is too high because of the VSD and is too young to repair the VSD. But PA banding is rarely necessary for infants with heart failure. Typically, you're not going to put it in kids with heart failure. The PA band does protect the pulmonary vasculature from developing pulmonary hypertension from the excessive flow across this VSD. Issues include cyanosis and residual increased pulmonary blood flow. But with the band, you're basically just putting a little band here, and you're increasing the pulmonary vascular resistance, so you end up having less left to right shunt. Anesthesia considerations during banding, often in CHF, but inhalation or opioid induction is acceptable, either one. But typically, inhalation induction is much easier. Increased pulmonary blood flow can be managed with temporary increases in PVR by decreasing FiO2 or hypercapnia. So you're coming in for the band because you have excessive pulmonary blood flow across the VSD. So the easiest thing to do is to increase the PVR by hypercapnia, little PEEP, maybe decreasing your FiO2. And then again, if the band's too tight, you can increase your FiO2. And typically it's 0.21 at the time of banding. And then an arterial line is often used to compare the pulmonary artery pressure at the time of the band. So again, art line, plus or minus, but sometimes it's very useful. So the bidirectional superior cable pulmonary shunt, known as the bidirectional Glenn procedure, is stage 2 of this. So what you're doing is you're basically just improving, if not getting all of the flow into the right atrium over into the pulmonary artery or pulmonary vasculature. And what you're doing is you're doing an end-to-side SVC here to right pulmonary artery shunt. You're clamping off the BT shunt, and you're also clamping off the right atrium so nothing goes into there. Oxygen saturation is usually improved dramatically, and this is done often by 3 months of age. Typically, the other two are done before 3 months of age. Anesthesia for the Glenn procedure, primary goals are to maintain the homeostasis of the PVR to SVR ratio, like any other cyanotic, where you're trying to balance the PVR and SVR so you've got enough blood flow to oxygenate the patient, but you've got enough SVR to avoid right to left shunting and to provide systemic perfusion. Ventricular performance is dependent on sinus rhythm, heart rate, preload, afterload, contractility, all these things. So this is one of those things where you got a pretty sick baby with system failure. Increased PVR, again, we hate to keep going over the same things, but it sticks a little better in the context of the procedure. But PVR increases are associated with hypoxemia, derecruitment, hypercarbia, atelectasis, acidosis, all those things. And then decreased PVR will increase your oxygenation, but also decrease systemic blood pressure. Invasive hemodynamics, vasopressor, and inotropic agents thus become an integral part of management in these patients that are typically kind of sick. Early extubation is nice, within a couple of hours, because positive pressure ventilation increases intrathoracic pressure, increases pulmonary vascular resistance, and all this stuff, which decreases pulmonary blood flow and is kind of counterproductive. The Fontan is pretty much the definitive procedure for a lot of cyanotics, and it's performed within a couple of years after the stage 2 operation, the bidirectional Glenn. But the Fontan is designed to redirect the entire systemic venous blood to the pulmonary arteries without a pumping chamber. In other words, you don't have an RV, you don't have a functional RA or RV. So the Fontan is usually performed at about 2 years, but can be done on infants. Pulmonary blood flow becomes extremely dependent on venous blood volume. I mean, if you've got no right ventricle and the blood is flowing into the pulmonary artery based entirely on the amount of volume that you got, you really need to keep them tanked up. So you can kind of see what the Fontan does is you got the SVC and the IVC all emptying blood directly into the right pulmonary artery. So you ended up improving your blood flow dramatically. Older children actually can get a pre-medicant, but you need to avoid the fast in these folks because, again, they're typically, hemoglobin is typically 20. They're also a little bit coagulopathic. Cyanotics with depressed ventricular function tolerate inhalation induction just fine. Nitrous is something that is, beauty's in the eye of the beholder. Don't like nitrous myself, but a lot of people really like it for second gas effect and to accelerate the inhalation induction, which, as we talked about before, with a right to left shunt can be an issue. Opioids improve management of poor function but delay extubation. 20 mics per kilo of fentanyl is nice. Arterial line, but not on the BT side shunt if you got a BP gradient. Typically, they get a central line. Typically, a hypoxia and atrial level shunts like an ASD is best managed with fluid, but in a VSD, it's better managed with phenylephrine. So, again, what are you doing with your fluid? What are you doing with your phenylephrine? You got a right to left shunt, so you're wanting to increase your SVR, so you have less right to left shunt. So you can either drop your PVR or you can increase your SVR, which is also going to improve your perfusion. So if you've got an ASD, which you typically don't have with tricuspid atresia, you can best manage it with fluid. Neosynephrine is a great drug for this. It's not just nose drops anymore. Post-CPB, maintain high filling pressures because, again, they're very dependent on venous return and the volume coming back because they don't have a right ventricle to push blood on through the pulmonary circulation. Also, you want to maintain a lower pulmonary vascular resistance, relative hypocapnia, 100% oxygen, low peak pressures, low PEEP, etc. Maybe even a little nitric oxide. Nitric oxide is good for everyone. CVP equals the pulmonary artery pressure. So, there's talk of putting pulmonary artery catheters in these folks, which is completely ridiculous. And then consider inotropic support. Milrinone is a great drug for that. But remember, milrinone is going to drop your venous return also. So you got to be kind of cautious because, remember, we're trying to keep high filling pressures in these folks. So some key points. Tricuspid atresia is characterized by an underdeveloped right ventricle, but also you have a tricuspid valve that's either non-existent or atretic. Reduced pulmonary circulation, a large left ventricle, a small VSD, which gets blood over to the right side, a PDA, and a patent foraminal valley. PGE1 should be started in neonates with tricuspid atresia. Severe cyanosis to maintain patency of the ductus. Atrial septostomy is also a very nice trick to improve pulmonary blood flow. And then finally, patients with TA with too little pulmonary blood flow receive a BT shunt, while those with too much pulmonary blood flow receive a pulmonary band. Typical doses of PGE1 are 0.05 to 0.1 mic per kilo per minute, and complications we talked about: apnea, seizures, fever, vasodilation. Management during BT shunt in the first stage includes an arterial line, plus or minus arterial line, no CVP or TE, extubation in the OR, and a little bit of heparin unless cardiopulmonary bypass is used. Again, it's a simple operation in a complicated patient. Increased pulmonary blood flow prior to banding may be managed with temporary increases in PVR by decreasing FiO2 or hypercapnia. And balancing PVR and SVR is essential during all congenital heart defect procedures. And we talked about the effects of ventilation strategies and FiO2 strategies on your PVR. So after a stage 1 and stage 2 operations, a Fontan is done, which redirects the entire systemic venous blood to the pulmonary arteries without a pumping chamber. So you've got no RV, and the pulmonary blood flow is entirely dependent on central venous pressure and adequate volume. Those cyanotic with depressed ventricular function, TA patients typically tolerate inhalation inductions, and high-dose opioids improve the management of poor function. So if you've got poor ventricular function, heart failure, etc., high-dose narcotic technique is the way to go with just enough gas to make it smell bad. Hypoxia and atrial level shunts are best managed with fluids. VSD associated with hypoxia is best managed with phenylephrine in these patients. Transposition of the great arteries is actually not that uncommon, but it's an extremely bizarre presentation. In transposition of the great arteries, also called transposition of the great vessels, the aorta and the pulmonary artery are each connected to the wrong ventricle. The aorta is connected to the right ventricle so that venous blood is carried to the body instead of to the lungs, and the pulmonary artery is attached to the left ventricle so the oxygen-rich blood is carried back to the lungs instead of to the body. So newborns with TGA survive only if they have one or more connections that allow the oxygen-rich blood to reach the body. And these connections may be in the form of a hole between the two ventricles or a PFO or a patent ductus arteriosus. The majority of these patients are hypoxic, very cyanotic at birth, and in general, if it weren't for these basically VSD, ASD, T, foramen ovale, or patent ductus, there wouldn't be any blood delivered to the body. So clinical manifestations involve cyanosis from birth, signs of congestive heart failure with dyspnea, feeding difficulties, but also you have parallel circulations with a degree of cyanosis depending on the blood flow across the septum. So you've got this, you got the RV going out the aorta and to the body and then straight back to the right atrium, so it's not really oxygenating anything. And then you've got blood from the LV going into the pulmonary artery, into the lungs, and coming straight back to the LA without oxygenating anything. So if it weren't for ASD or a VSD blood, oxygenated blood going over to this right ventricle, it would never quite make it. So it's a very complicated circuit that actually has a pretty, not simple, but relatively simple repair. So looking at this a little closer, you have parallel circulations. So along with the truncus arteriosus, which we'll talk about a little bit later on, transposition of the great vessels has two independent circuits, as we can see here. It's got one that's very oxygenated, one that's completely deoxygenated, and then pulmonary blood flow crossover across an ASD or a VSD. And then again, the shunt is left to right and right to left. It just kind of depends on what you do with the pulmonary vascular resistance and the SVR. And again, you can also have a PDA in here somewhere. So medical management, obviously oxygen, arterial blood gases, and management of the metabolic acidosis that comes from not having enough systemic delivery of oxygen. Also, PGE1 should be started to improve arterial oxygen saturation by opening the ductus, whether they have a VSD or not. That always helps. Also, if you've got a smaller ASD, or if you don't have any ASD, sometimes you can open the patent. You can make the foramen ovale patent, or you can create an ASD with a Rashkin procedure. So surgical management, arterial switch procedure is performed during the first week of life. So you're basically taking the pulmonary artery and you're putting it back on the RV, and you're taking the aorta and you're putting it back on the LV. Now, of course, you've got coronary arteries, so you're going to have to do a little reanastomosis here to the new artery that you've got coming out of the LV, the aorta. So coronary arteries are reimplanted into the systemic great vessel of the aorta, so you can end up getting oxygenated blood down the coronaries. So back to our heart as a house, you've got basically blood coming out of the left ventricle and going into the pulmonary artery, and you got blood from the right ventricle going into the down to the aortic arch that's deoxygenated. So you got very oxygenated blood and completely deoxygenated blood. So if you're going to repair it, you're going to go ahead and do the arterial switch. You put the pulmonary artery over here, you put the aortic artery over here, and then you reanastomose the coronary buttons to the aorta. So anesthesia goals in patients with transposition. You've got IV drugs that are delivered to the heart and the brain completely undiluted, while the inhalation agents have a delayed onset. So ketamine and non-depolarizing muscle relaxants are very useful in this regard. Decreases in cardiac output decrease systemic venous saturation with resultant fall in arterial saturation. So volatile agents, again, aren't very useful in this situation, and you're using high-dose opioid technique. You got to maintain the ductal patency until you get on pump, at least in ductal dependent patients with PGE1 at the dose we talked about before. We're going to avoid increases in pulmonary vascular resistance relative to SVR. Increases in PVR are going to decrease pulmonary blood flow and reduce intercirculatory mixing. So just about the time you're figuring out what PVR manipulation and SVR manipulation do, then now we've got the transposition of the great vessels, so it makes no sense whatsoever. So just bear with me for just a minute. So in patients with pulmonary vascular occlusive disease, ventilatory intervention should be used to decrease the pulmonary vascular resistance. And so reduction. So basically, you're just balancing your PVR and your SVR. And SVR gets too low, you wind up having hypoperfusion, then you end up needing to get some phenylephrine or some type of inotrope. And then maintain hydration, as the PCV is typically 70% and thrombus is very common in these patients. So before you start considering a career in a ketamine clinic after suffering through this presentation, let's just get through a couple more very big congenital defects. Truncus arteriosus is a very fascinating problem. The aorta and pulmonary artery start out as a single great vessel, which eventually divides and becomes two separate vessels. So the truncus arteriosus occurs when the single great vessel fails to separate completely like it's supposed to do in embryo, leaving a connection between the aorta and the pulmonary artery. It's usually accompanied by a VSD as well, which allows some mixing to occur if you end up having too much flow in the aorta and not enough in the PA, and vice versa. Oxygenated and deoxygenated blood mix in the ventricles and flows through the common truncal vessel. Some of the blood flows to the PA, some to the aorta. Shunt causes cyanosis in the overloaded pulmonary circuit. So you got pulmonary circulation overload, and you've got deoxygenated blood going down the aorta to the tissues. So in an attempt to use the heart as a house to avoid any confusion, what happens basically is you've got cyanosis seen immediately after birth. You have signs of heart failure developing within several days to weeks after birth, with bad issues with feeding, dyspnea, failure to thrive, etc., frequent URIs. And you got a very wide pulse pressure with a systolic click. What you've got is you've got blood coming to the left ventricle, blood coming to the right ventricle, and you have a VSD, so there's some mixing of blood. But on top of that, you're really getting a mixing of blood as the blood comes out through a common conduit. So some blood's going into the pulmonary artery, some blood's going to the systemic circuit, and both are deoxygenated, basically. So you're running around with almost a venous sat at the bedside. Surgical treatment is through a Rastelli operation, where you're excising the pulmonary arteries from the aorta. You're attaching the pulmonary artery to the right ventricle with a homograft. So you end up having its own circulation by attaching a homograft to the right ventricle. So you're creating a pulmonary RV outflow tract, basically. And you're going to close the ventricular septal defect. Big operation, huge operation. There's a lot of heart failure associated with it, and the mortality is greater than 10%. Probably one of the highest morbidity mortality operations that you can do with congenitals. So using the same heart as a house model, you've got the truncus, you've got the VSD, you've got the common outflow tract, you've got deoxygenated blood going everywhere. So what you're doing with the repair is you're going to close off the VSD. You're going to create a little conduit over to it's a little dacron that's going to go from the RV directly into the pulmonary artery, and then you're going to exclude the PA from the aorta, and you're going to then have hopefully oxygenated blood going out to the rest of the body. So some of the anesthesia considerations involve optimal management of the pulmonary vascular resistance and magnitude of pulmonary blood flow through the truncus. So patients with low PVR benefit from measures to increase PVR and decrease pulmonary blood flow, and it's going to improve your systemic blood pressure. This includes PEEP, pulmonary artery banding, but that's again palliative procedure. If you're going to drive up your pulmonary vascular resistance, think about what you're doing with your ventilation. You're putting some PEEP on. You're you're going to drop your FiO2, you're going to allow some permissive hypercapnia, all to increase your pulmonary vascular resistance. So most of the blood goes down the aorta. Patients with increased PVR benefit from measures to decrease PVR and improve hypoxemia. That's, a lot of this is just a balance of SAT versus systemic flow. And a lot of times, if you're looking at children in the OR and you're trying to figure out what their tissue perfusion is, and a lot of that has to do with what you're reading on your end-tidal CO2. Airway issues can exist in all of these patients: facial deformities, tracheomalacia. So an airway is, this is not a guaranteed thing. 100% oxygen can decrease PVR and cause hypotension, so you have to be careful. Oxygen sat of 60 to 70% may be optimal, which is a little bit of a stretch. And when you get below 85%, your pulse oximeter starts to really separate from what your real SAT is in your body. So propofol and nitrous oxide are typically avoided, at least according to some of the more contemporary work. And finally, typically moderate doses of opioids, supplemented with volatile, just a little volatile, is the way you deal with this from an anesthesia standpoint. So finally, we get to the key points. With TGA pathophysiology, oxygen-poor blood returns to the right atrium from the body, through the right atrium and right ventricle, then back to the body as a parallel circuit. Oxygen-rich blood returns to the left atrium from the lungs, through the LA and LV, then into the pulmonary artery and back to the lungs as a second parallel circuit. So you have to have an ASD and or a VSD or a PDA or foraminal valley, whatever connection you got between the two circulations, or else you got no oxygenation occurring. Prior to definitive surgical correction, prostaglandin infusion should be started to improve arterial oxygenation. And balloon atrial septostomy may be done as well to increase mixing and PO2 by opening an atrial septum. So improving flow between those two parallel circulations. And then finally, maintenance of ductal patency and SVR are very key anesthesia goals during arterial switch procedures for TGA. Obviously, keep your PG1 going and keep your SVR up, maybe ketamine and a little opioid, things like that. There's a truncus among us. No, truncus arteriosus occurs when a single great vessel fails to separate completely, leaving a connection between the aorta and the pulmonary artery. It's a very bizarre circuit. And it's usually accompanied by a VSD and oxygenated, deoxygenated blood mixing the ventricles and flows through the common truncal vessel. You get cyanosis from it. Surgical treatment involves excising the pulmonary artery from the aorta and attaching the pulmonary artery to the right ventricle with a homograft. Very complicated operation. Lots and lots of hemorrhaging. 100% oxygen can decrease PVR and cause hypotension, such that you should probably shoot for an oxygen sat of 60 to 70%. If you're looking for how do you know if your PVR and your SVR are balanced, it's probably oxygen sat of 60 to 70%, and you're getting a pretty reasonable end-tidal CO2 on your end-tidal CO2 monitor, which is in pediatrics, it's a poor man's TEE. The main characteristics of hypoplastic left heart syndrome, or HLHS, or as those in the business call it, a hypoplast. And in Tennessee, it's, the fewer the syllables, the better. The main characteristics are marked hypoplasia or underdevelopment, or even absence of the left ventricle, and severe hypoplasia of the aorta. Often a localized pinching or coarctation of the aorta is also present. The main PA is enlarged and gives rise to a very large ductus, and this allows blood to flow from the right ventricle into the aorta and out to the body. Other characteristics of hypoplasts often include a combination of aortic and mitral stenosis or aortic and mitral atresia. Very severe form of congenital heart disease. Without surgical intervention, it's pretty fatal and often diagnosed within 1 to 2 days after birth. Basically, the symptoms appear when the ductus starts to close. And so there's 3 options for treating these children. You can either supportive care or stage reconstruction of the heart or a heart transplant. And stage reconstruction typically involves stage 1, which is the Norwood, stage 2, which is the bidirectional Glenn, and 3, which is the Fontan. So it's a very complicated disease. And again, the PFO or an ASD sometimes does this as well as the PDA. And then HLHS occurs in 1% of all congenital defects. Fortunately, it's like number 10 on the list. So basically, there's prostaglandin is going to maintain ductal patency while it does the baby gets the stage 1 procedure, which is anastomosis of the main pulmonary artery to the aorta to create basically a new aorta, and then the placement of a shunt or a conduit from the PA or aorta or BT shunt to provide pulmonary blood flow. And in addition, you create a large ASD with a Rashkin procedure. So it's very complicated. The Norwood's a very complicated operation for a very complicated situation. Stage 2 is a bidirectional Glenn shunt at 6 to 9 months to relieve cyanosis and reduce the RV overload. And we talked about the Glenn shunt in a previous defect. And then the Fontan to redirect all venous blood through the lungs. Again, there's no RV, just venous pressure drives the flow in a Fontan. So again, using the heart as a house, you've got a very underdeveloped left ventricle, very little blood flowing out through a very small underdeveloped aorta. Then you've got a huge right ventricle and all this blood flow. And you've got a ductus keeping blood flow going from out to the body. So what the Norwood does, this stage calls for a homograph to be used to enlarge this rudimentary aortic arch here and then join it to the pulmonary trunk. The pulmonary trunk's been disconnected from the left and right pulmonary arteries, and then the newly created blood vessel functions as the patient's aorta. The right ventricle then becomes the common aorta, pumping blood through the aorta to the rest of the body. And then blood flow to the lungs is provided by means of a modified BT shunt, which is going to go here. That's going to hook up to the pulmonary artery from the ipsilateral subclavian. So you're going to go right subclavian to right pulmonary artery with this BT shunt here. So it's a very convoluted way of managing it, but it actually gets the kid to the next stage. So with the Norwood, higher oxygen concentration or higher FiO2 is going to improve the SAT but decrease systemic perfusion. So typically they're on 0.21 or less, even subatmospheric FiO2, because if you really decrease the pulmonary vascular resistance, you're not going to have any blood flow down that atretic aorta. So perioperative factors include severe hypothermia, circulatory arrest, long pump runs, post-pump ventricular dysfunction. It's a really big operation with a lot of stuff. High-dose opioids with again, just enough gas to make it smell bad. Dopamine or epi is nice because you get some sympathectomy from the opioids. Nasotracheal intubation, typically because the operation and the emergence and the ICU time is so long. So often, again, they're neonates, so maybe an umbilical vessel may be used to monitor pressures and give volume. Oxygen saturation management is the key, as hypoxia is difficult to avoid, but hyperoxia is bad. And in sternal closure, often they leave the OR with the chest open and wait for a couple of days for the swelling to go down. So we talked a little bit about the Glenn before, but it's a very nice intermediary between the Norwood and the Fontan for patients with for the hypoplast. So using the heart as a house, again, what we're going to do with the bidirectional Glenn shunt, we're going to connect the superior vena cava here to the right branch of the pulmonary artery, to the right PA. And as a result, venous blood from the head and upper limbs will pass directly to the lungs, bypassing the RV. And then the venous blood from the lower half of the body will continue to return to the heart here and then come out here. So you end up avoiding the risk of failure of a big Fontan operation until the kid gets a little bigger. And the procedure decreases the volume of blood delivered to the single ventricle, thus reducing the amount of work the ventricle performs. Typically, it creates a more favorable setting to complete a Fontan construction at about 2 years of age. So you did a successful Glenn operation. You're going to basically take now the IVC blood and you're going to make it run all the way over to this same pulmonary artery circuit now. So it's a complete circuit, and it should be getting all the venous blood that is going to go straight over here and reduce the workload of the RV. Again, it's just a very big operation. And if you do it in stages, Glenn first and then the Fontan, I think it is, despite two big operations, it's much easier to manage and the morbidity mortality is much lower. So anesthesia considerations for the completion Fontan. Arterial and central venous lines, cerebral oximetry, even atrial pressure is part of the completion of Fontan. Induction with an opioid, 20 to 50 mics per kilo of fentanyl and non-depolarizing muscle relaxant. Then minimal, if any, use of volatile. Issues involve a low systemic output, myocardial dysfunction, shunt, very, very sick. Lots of issues can arise, including ventricular fibrillation, especially when they spread the chest. Goals for assisting the ventricle include increased inotropy and reductions of SVR and PVR. You're basically a single ventricle. You've got a left heart that's not really working, the right heart's doing all the work, and then the right heart is doing systemic perfusion, and the venous return is coming through your the shunts that you've created with the Glen and the BT. And then combination of inotropic support and reduction of PVR and SVR is used. So basically, dobutamine and milrinone are very useful drugs. Sometimes dopamine and isoproterenol is cultural, depends on where you work, and everybody thinks their technique is much better than everybody else's. RV contractile function is absent, and perfusion of pulmonary circulation is passive. So RV is really the dysfunctional LV, but you've got no RV function at all. You're basically getting blood over to the pulmonary circuit through the Glen conduits. Maintaining low pulmonary vascular resistance and prevention of elevated SVR. And typically, if you're wanting to manage your PVR, you're going to use ventilatory regulation, which is the easiest. Although milrinone and isoprel are going to help you out with that as well. But typically, you're going to use FiO2 manipulation, you're going to use PEEP, etc. So, Epstein's anomaly is a congenital heart defect in which the septal leaflet of the tricuspid valve is displaced towards the RV. The septal and posterior leaflets are displaced downward into the RV, and a portion of the RV is incorporated into the right atrium. An ASD is usually also present, and the right atrium is massively dilated in hypertrophy, such that you often get conduction issues and atrial arrhythmias, especially WPW as later on in life, and SVT, etc. Cyanosis is the initial complaint in the neonatal period, and then heart failure develops in the first few days of life. Again, I've taken care of some Epstein's patients as adults that were unrepaired, but in severe presentations of Epstein's anomaly, which is where you're going to see them in the first 24 hours, first 72 hours of life. Effective output from the right side of the heart is decreased, if not almost absent. You have a poorly functioning small RV, severe TR, obstruction of the RV outflow tract by the large sail-like anterior tricuspid leaflet. So you got this big tricuspid leaflet that's impinging upon the RV outflow tract, sort of like you've got some type of issue with hokum or something. But you wind up having the blood flow across into the PA diminished. Increased volume of right atrial blood shunts through a foraminal valley or an associated ASD to the left atrium and produces cyanosis as well. Some of the clinical manifestations on the EKG and chest X-ray and echo, again, here you've got this very nice little ASD. You've got this very small RV, huge right atrium, big enough that you could sit inside and sew, as one surgeon says. But milder cases complain of dyspnea and fatigue, cyanosis, or palpitations. That's what you see a lot in some of the adults. But in general, medical management involves the PGE1 infusion, inotropes, and correction of metabolic acidosis, especially in severely cyanotic neonates. DIG and diuretics are indicated for heart failure as well, and the SVT is typically treated with a little bit of adenosine, maybe some oral DIG or verapamil as well. Chest X-ray reveals a balloon-shaped heart and decreased pulmonary vascular markings, and in general, it's a pretty sick baby. We talked a little bit about medical management, including inotropes and PGE1 and intubating and mechanical ventilation to modify the PVR. But surgical manipulations also possible, or management with a palliative VT shunt. Starnes operation can be done to reduce the right atrium, and some classic Glen anastomoses can be considered in extremely cyanotic infants. And then finally, tricuspid valve repair, which is desirable, or replacement, which is often done, may be indicated as well. Anesthesia considerations in patients with Epstein's. Major concerns include a decreased cardiac output, hence the acidosis, a right to left atrial shunt with cyanosis, and propensity for atrial tachyarrhythmias. About 30% also have a probe-patent PFO, which of course we talked about already, but that's going to lead to a little bit more cyanosis. If you're going to sleep with inhalation induction, it takes a while. If you're giving IV drugs also, it has been known to decrease or increase your induction time. Minimizing PVR, optimizing RV preload, maintain contractility are the rules of the day. Inhaled nitric oxide lowers the PVR, and often neonates arrive with a PGE1 infusion. The inhaled nitric is for people that have really elevated PVR, and of course they have to be intubated. Marginal ventricular function benefit from an opioid technique, as always. So you kind of seen the trend here. You go into the pink babies, the acyanotic defects, they're handled pretty well with volatile. Some of them extubate on the table. But when you get into the cyanotics, typically you're using higher doses of opioids because they're a lot sicker. And then finally, these patients are sensitive to atrial arrhythmias, especially mechanical, when you start messing around in the chest, and injury-induced heart block. So some key points about Ebstein's. It's characterized by a small true right ventricle and a portion of the RV that's just another right atrium, so preatria. Severe presentations of Ebstein's involve a poorly functioning small RV with severe TR and shunt. Major concerns include decreased cardiac output, acidosis, right to left shunt, cyanosis, and dysrhythmias. Adenosine should be immediately available in the OR, and minimizing PVR and optimizing RV preload and maintenance of contractility is a very important step and may include nitric oxide with some basic ventilation strategies.